Państwa na drugim dniu konferencji Urban Drug Policies. Dzisiaj rozpoczniemy od panelu na temat sytuacji w Europie Wschodniej i na Bałkanach. Wystąpią pani Dasha Matyushina-Ocheret, która pracuje w organizacji Eurasian Harm Reduction Network. Zajmuje się problematyką redukcji szkód na wschodzie, szczególnie w krajach byłego Związku Radzieckiego. Pani Irena Molnar z serbskiej organizacji Regeneration, która zajmuje się redukcją szkód i ogólnie polityką narkotykową w Serbii i na Bałkanach. Oraz pan Aleksander Ciechanowicz, który mam nadzieję niedługo do nas dotrze, który zakładał pierwszy program redukcji szkód w Rosji w Sankt Petersburgu.
So my name is Dasha Matyushina-Ocheret and I'm coming here actually from Moscow, but I work with Eurasian Harm Reduction Network based in Vilnius. So I kind of represent two countries. And I was speaking about the situation in Eastern Europe and Central Asia a little bit. But, you know, of course, a presentation covering drug policies and related negative consequences would take more than 10 or 15 minutes. So I would just give a couple of highlights of what's happening in the region right now and how we can work together on the regional level to move in terms of drug policy reform in Eastern Europe. Yeah, so the main idea that we have in terms of drug policy advocacy in Eastern Europe and Central Asia is that there is still no consensus among the civil society or no consensus among different countries of the region how and if drug policies should change. So we see very different countries. It's hard to compare the situation in Russia with the situation in Estonia or the Czech Republic with Ukraine, for instance. And we see that people do not still agree on, on what should be the direction of drug policy reform. But what we can agree already is that repressive drug policies in Eastern Europe, in fact, led to harsh unintended consequences. So this term unintended consequences in drug policy context has long history already, but it was reintroduced in 2008 by the former executive director of UNODC in his report in 2008 when he acknowledged on the highest international level that even though from his point of view, from the UNODC point of view, drug policies in the world were quite effective in terms of reducing the number of, the amount of production of, heroin and cannabis, but at the same time they had led to harsh unintended consequences. So Eurasian Harm Reduction Network actually created a framework to assess unintended consequences in the region, and I think that here is where we can get common grounds with different sectors of the civil society and with the state. So we have identified, it's nothing new actually, we just grouped those unintended consequences of repressive drug policies in 6 areas. Negative health impact of drug policies such as HIV, hepatitis C, TB, and overdose mortality. Social impact, such as increased stigma against people who use drugs and their families in the society. We believe that this is a result of repressive drug policy. I would say this is intended consequence, not really unintended one. And also massive incarceration of people who use drugs. It's also negative human rights and equity impact, a very important thing which we have called transparency impact, and we have included here such examples of corruption and also low access to fair trial, which drug users have in all the region, I think. It's also policy impact. which from our side we see as low level of domestic funding to harm reduction programs and ban on methadone programs in many countries, and also substance displacement, which resulted in appearance in drug markets such harmful substances as desmorphine, bath salts, spices, etc. So when I was preparing to speak here, I decided that I will pick a few examples, some of which you may have heard, some which will be new to you, to illustrate different unintended consequences. So in terms of health impact, just a few figures here. In Moldova, in Belce, HIV prevalence among people who inject drugs was almost 50% a couple of years ago, and it still remains the same, even though we see that in many countries there are less new cases of HIV among drug users registered every year. The overall prevalence in some cities is still extremely high. If we look then an example of Estonia, I don't know how well you can see from there. Yeah, but in Estonia, for instance, almost 70% of newly diagnosed HIV cases among people who inject drugs have very low CD4 count, less than 350. I don't know how well the audience here knows, the situation with the development of HIV infection and epidemiology, but this indicator, it actually shows that most of these people had HIV many years prior to the moment they were diagnosed. And they already, first of all, they already needed treatment and could have developed a lot of consequences and opportunistic infections, and they also could have spread HIV to a lot of other people with whom they either had sex or injected drugs. So that's a very important indicator, and unfortunately we do not have a lot of data like this from all countries of Eastern Europe and Central Asia. In Georgia, prevalence of hepatitis C among people who inject drugs reaches 80%, and I would say 60 to 80% is the regional average for hepatitis C prevalence among drug users. Opioid overdose still remains a leading cause of death among young people in Europe, but most of overdose cases remain not unregistered. The death is registered, but the cause of death is registered under some other categories. In Tajikistan, for instance, we hear almost daily or weekly reports of drug users activists who died, or outreach workers who died because of heroin overdose, but we do not see it reflected in the country statistics at all. The indicator there is like 0 because no one collects this information. I could continue giving you different examples of this negative health impact of drug policies, but I would say that today we all know that repressive drug policies systematically lead to this negative health impact. We can't call it unintended because we already have seen during the last 2 decades at least that there is a logic between prohibition of drugs, harsh police actions, and these kind of consequences. In terms of social impact, just a few facts here. In Georgia, the possession of any amount of drugs leads to more than 7 years of imprisonment. Anything more than 0. Drug use is also a criminal offense. When caught for the first time, you just have to pay fine, but if you get arrested for drug use for the second time, it's again imprisonment for 7 years. In Latvia, which is part of the European Union and which claims to have balanced drug policies, at least this is what country officials say, drug possession of more than 0.001 gram of heroin can be charged with 280 euros. Like, this is the amount that you even probably can't see without microscope. In reality, this means that any amount of heroin found in a person can lead to a very large fine, given the unemployment rates in the country. It's approximately, I think, a monthly salary for a drug user. In Ukraine, in 2010 alone, over 15,000 young people were sentenced due to drug-related crimes, and 2/3 of these crimes were with no intent to sell drugs. And I'm afraid that the situation didn't change for better, but unfortunately that's the latest statistics that they provide. Human rights and equity impact. Probably it was not a very good idea to place white color on green, but I can read something there. We have started a platform, a regional platform, and I recommend all of you to visit our website, harmreduction.org, and see it, and you can join this campaign, even though it started a couple of years ago. So during the first year of this regional campaign, Women Against Violence, we have got 850 reports of policed violence against women who use drugs. Among that, it was 121 cases of sexual violence, 322 cases of physical violence, and they were like 0 cases started against police. All of these violations remain unreported or undocumented, and the state does nothing to actually prevent or reduce this. Women who use drugs are less likely to have access to harm reduction services. And we also see it as an equity impact of repressive drug policies, because women, like, no one has the right to use drugs in our societies, but women do not have this right at all. And they face double stigma. So we see that very small numbers of women who use drugs access methadone treatment. Less than 3% of women are clients of methadone programs in Georgia, and there is like no women who have access to methadone in Azerbaijan. So in most of prisons of the region, you will not have access to neither methadone or needle and syringe programs. Lithuania remains the only country of European Union which still prohibits any harm reduction measures in prison settings. But in most of Eastern Europe and Central Asian states, it's the same. The last example would be related to policy impact. Of course, there are much more negative consequences of repressive drug policies, but being a representative of a harm reduction network, I will give you examples related to harm reduction mainly. So Georgia currently projects no domestic funding for needle and syringe programs this year, next year, and until 2018. So their contribution by the end of 2018 would be less than 2% of domestic funding. So needle and syringe programs, they fully depend on availability of funding coming from the Global Fund. Moldova and Tajikistan, they are going to provide state funding for harm reduction programs below 15% and 2% respectively. The Lithuanian government is the only donor at the moment for harm reduction programs in the country, but they cover only 37% of the demand for harm reduction programs. It's because of drug policy. Methadone and buprenorphine is prohibited in Russia, Uzbekistan, and Turkmenistan. And in none of non-EU states, methadone take-home doses are allowed, which means that in Belarus, Ukraine, and now Azerbaijan, like whatever country, Kazakhstan, Tajikistan, whatever country of Eastern Europe and Central Asia you pick, people have to go to methadone clinics daily to pick their dose, even if they are for 5 or 10 years on methadone, and this, of course, violates their freedom and decreases their capacity to find jobs or to take care of their families and their children. And this is also, this over-regulation of methadone is related to repressive drug policies. So the situation is bad. Why do we think that it can change now? Like, first of all, we see that there is no consensus that drug policy should be repressive. The consensus, this global consensus that we all should have war on drugs and immediately stop drug use in the world, such consensus we had in the end of the 90s, it's ruined now. There is diversity of opinions, at least informal opinions, if we talk about Eastern Europe and Central Asia. And more countries decriminalize drugs or legalized cannabis, not in our region, but still there were even formal attempts in Baltic states on legalization. What we have to do, we have to increase this understanding that repressive drug policies lead to unintended consequences, and we have to document it, not just for the UNGAS, which will happen in less than 2 months in New York, but beyond UNGAS. So we believe that the drug policy debate will not stop after the UNGAS on the world drug problem in April. We believe that for many countries of this region, it will just start. So what we call you to, first of all, have a look at the regional position of Eurasian network of people who use drugs and EHRN, which will be distributed during the coffee break, and to provide your comments on our website. And the website is, you will find it on the papers distributed. But we also ask you to document and send to us unintended consequences. So what we're going to do, we're going to collect information, data from drug user activists, from harm reduction programs, from scientists, from state actors of all countries of Central and Eastern Europe and Eastern Asia, and map it to have this regional picture of how prohibition of drug use and of prohibition of and criminalization of drug possession, how it has led to public health and human rights and social crisis in many places of the region. Thank you.
So what I'm about to speak about is general situation about drug policy in Serbia. I will give you briefly how new national strategy for drugs looks like, and also I will give you comments about action plan in that strategy, because they are not in line at all. Afterwards, I'm going to speak a little bit about harm reduction programs and transition period from when Global Fund left, and about something that our organization did recently. So, National Drug Strategy Framework defined demand reduction priorities as the best practice promotion, quality standard development for prevention, early detection and intervention, risk assessment and harm reduction, treatment and rehabilitation, resocialization and recovery. When you read something like this, you think that's an ideal thing for a strategy to have, but in action plan, there is no actions dealing with these things. For about improvement of availability and accessibility of risk awareness, rising prevention programs, and healthy lifestyle promotion, it's not even stated what they mean by healthy lifestyle promotion, regarding that in Serbia it's completely socially acceptable using alcohol since kids are 14. Not to mention the rest of the things. Development of effective demand reduction measures with special focus on polydrug use, abuse of prescription medicines, and new psychoactive substances. We as well don't have any activities in action plan regarding these issues. Development of overdose prevention measures and prevention of communicable diseases. Critical harm reduction interventions such as needle exchange programs or condom distributions, community outreach, targeted informational material distributions are discontinued due to lack of funding. So since Global Fund left, we don't have these programs. Improvement of availability, accessibility, and coverage of effective treatment options for both opiate and non-opiate users. In Serbia's situation with drug treatment, it's available in different forms. But things like drug-free rehabilitation program and opium substitute treatment. For example, opium substitute treatment, since Global Fund left, we have 29, now we have 25, which is kind of a good thing that the funding didn't cut on these ones. But for non-opiate drug users, we don't have any kind of treatment. Improvement of accessibility and efficiency of demand reduction measure in prison settings. It's a priority to be equivalent to one in non-incarcerated system. But the positive thing is that the government also took over HIV prevention program in 12 prisons. Development of integrated models of rehabilitation and social support in order to improve social reintegration and recovery process. We don't have any measures for this. There is only one church-based support group, which is actually survived tremendous how to say, there were some deaths in the church settings. In the church, they were doing harm reduction. So yeah, and we have development of effective measures to postpone drug use initiation with special focus on vulnerable populations. It is quite unclear in the strategy and in action plan what is exactly, what are they, how vulnerable populations are defined. We have drug control, so national legislation is directly related to control of psychoactive substances, and it has 2 laws, as you can see. I'm not going to speak much about all of them, but this is indirectly regulate control psychoactive substances laws. What is crucial for this is that laws on psychoactive controlled substances were regulated through 4 acts, but no relations to the prevention and treatment of persons who are using psychoactive substances. In 2005, we had Article 246, which is article who criminalized authorized keeping, production, and distribution of narcotic drugs. The thing is that the things like production, distribution, and unauthorized keeping for personal use were not divided. So any amount for any reasons of this you could be charged for 0 to 3 years of prison or more. It doesn't matter which substance you use and why do you have it for any kind of reasons. So that led to increase of incarceration of young people who had small amounts of psychoactive substances for personal use. In 2012, this criminal law had amendment, and they added Article 246A that divided personal possession of small amounts for personal use divided from production and distribution of drugs. By this law, then happened that possibly you can get free or you can be fined, like financially fined, but also you can have up to 3 years of prison. It depends on difference in between of the cities, for example, and between of the other part of Serbia is that the personal attitude of the judge pretty much decides how you're going to be fined, because in the parts they're not big cities, and when judges are not used to having these kind of charges, you can get pretty much up to 3 years of prison if you are possessing small amounts of personal use in like southern Serbia or the small cities or even small municipalities. What is interesting here is that you can also be released if you admit where did you purchase your drugs or psychoactive substances, even though by the Constitution forbids extortion of the testimony. So that is a bit of tricky for now. Harm reduction programs, since Global Fund support allowed Serbia to scale up harm reduction services between 2006 and 2014, including needle exchange programs, opium substitute treatment, and outreach activities. The Serbian government acknowledged the importance of this work and pledged that it would maintain these services as Global Fund leave. However, as of July 2015, the government was supporting only a portion of these programs, mainly in prisons, HIV prevention programs, failing to fill the financial gap for the others that risk closing as a result. Opiate substitution treatment have been available in Serbia since late 70s, but by 2013, a substitution program was available in 29 primary, secondary, and tertiary health facilities due to largely to Global Fund assistance in 26 of them. Methadone programs was also established in penal institutions for prisoners already on treatment, and in some cases new patients. By the 2013, the estimated was 2,460 patients and 143 prisoners were receiving opium substitution treatment. However, the situation with other harm reduction services is less optimistic. Needle exchange program was introduced in Serbia in 2002, but by 2013 was available in 4 largest cities, Niš, Novi Sad, Kragujevac, and Belgrade, of course, reaching an estimated number of 4,285 clients. The 4 programs were funded almost entirely by a global fund, and between 2014, with the exception of Kragujevac, which project closed prior to Global Fund's departure. The organizations had annual budgets ranging from 30,000 to 50,000 euros, which enabled them to conduct outreach, trainings, provide trainings on health and risk management, and run drop-in centers where people who use drugs could gather, assess health and social services, and attend support groups. Losing Global Fund's money has severely limited the ability of these organizations to continue their life-saving services, with the exception of Novi Sad in Vojvodina, where local governments provided small amounts of funding to non-governmental organizations working with people who use drugs. Transition period showed lack of transition plan for Global Fund's withdrawal, lack of efficient institutional framework for conducting the transition to domestic financing for HIV and AIDS. HIV prevention, especially among key population, is low priority for the government for now, and there is no alternative mechanism to ensure sustainable funding for NGOs. Regeneration did one biggest national and first national research on in party setting within the Youth Organization for Drug Action project in 2013. And what we did clubbing and youth health research among 3,500 young people who go out in nightclubs. Research showed that risk behavior patterns and practices are very common, and some of the most frightening one was that every 10th person who tried substance didn't know what that substance was. 67% of people who use stimulants drink alcohol with it, while 25% doesn't drink water at all. 52% of people who snort psychoactive substances share their sniffing tools, while most of them, 83%, use banknotes, which is like really. What are the challenges of harm reduction with youth programs in Serbia is that we don't have nightlife outreach programs even when the situation is critical like this. We don't have drug checking programs on parties and festivals, even though the research showed the big emergence of new psychoactive substances and lack of knowledge among young people what they're doing and how to do it. Lack of accessibility of needle exchange program to young injecting users, because we don't have any needle exchange program now. Even when we had it, young people weren't able to go to them. We have questionable sustainability of needle exchange program in general, as I said, but the lack of specific program for young people, recreational and problematic drug users also is a problem. What we do think is that stakeholders must take action to ensure transitional period from global funding to now, and also government, civil society, and donors should consider strategies to ensure transition process and implementation of action plan in national strategy that should be in line. As I said, like when Global Fund was in Serbia, some programs were operating, but now Serbia is going to be in the process where we can use accession funds of EU. What we are afraid of is that government is going to plastically use that money to infuse it and start some programs, but we are afraid as well that those programs are not going to be sustainable, and soon as we are out of accession financing, we are going to be back at the beginning. Thank you.
Dzień dobry, szanowni państwo. Przede wszystkim przepraszam za spóźnienie, tak się zdarzyło. A po drugie chcę podziękować za możliwość mówienia o doświadczeniu rosyjskim w rozwoju polityki narkotykowej, dlatego że dla mnie to jest ważne, dlatego że Rosja jest trochę niby to wyłączona, ale może raczej samodzielnie jakoś skroczyło z tej drogi magistralnej rozwoju polityki narkotykowej. No i postarać się powiedzieć o tym, co można zrobić w takim kontekście. w ramach tego, ja bym powiedział, zboczeństwa. But I'm sorry, as soon as I have my presentation in English, I will speak English. So I accentuate here in my presentation the problem of hostile context. Thanks to Dasha's presentation, I think I will not speak a lot about this because Dasha presented well, but I'll try to give a little bit more details. Just some epidemiology context. With about 5 million of population in St. Petersburg, the estimated number of people who use drugs is goes from 35 to 70,000 people. Heroin is still the main drug. However, synthetic highs are more and more observed, present on the scene. The problem of overdoses is really very acute. The majority of death among drug users is due to overdose. As soon as harm reduction is kind of an emanation of struggle against HIV, it's important to say that in St. Petersburg, there are, it's just for the last year, 51,000 registered cases of HIV. Only 1,733 new cases were registered only for the half year. And as usually, drug use is the main way of infections. Even if the last year, they say, the health specialists say that sexual way is a little bit more important than the parental way. Well, now context. I should say that the context is in some kind paradox. Why? Because on the national level, always I'm basing on Dasha's presentation, the situation is, I should say, terrible. I'm not afraid of these strong words because it's just the reality. On the other hand, there are some attempts to elaborate a rational attitude to drug policy on the local level. In my case, on the level of the city of St. Petersburg. Well, why hostile context? Drug possession is penalized by the law. Then there is a structure in Russia which is called the Federal Drug Control Committee, which defines everything what is connected with drugs. So this Drug Control Committee says no to substitution. Even to mention substitution can be dangerous, especially for health professionals. Syringes exchange is not allowed. Officially, they are against this, say this is promotion of drug use. But they are in the position to tolerate, hardly, but tolerate syringes exchange because of the strong support of health professionals. Naloxone is not accessible for distribution among people who inject drugs, I mean opioid drugs. It's not prohibited, but it's not allowed. Only medical doctors can do this, but you can imagine the situation in the reality in the field when someone has the overdose. who will go and take prescription, doctor's prescription just to save their life. Rehabilitation, so-called rehabilitation, is only on the base of the faith-based organization. This is a unique alternative to prison in the vision of the Drug Control Committee. But we all know very well which are the results of such a rehabilitation. Then, policy. I think everybody agree with me that Russia is not a country of democratic culture. There is no democratic tradition. There is no political will on the national level. As I told, on the national level, like a desert. The last declarations of Prime Minister and the Minister of Health about even Putin somewhere told just a couple of words about HIV epidemic, but no one word about drug users. So the Prime Minister and the Minister of Health speak about necessity of funding of preventive programs, but we were expecting, or some people were expecting, the others no, the increase of funding. Finally, with economic crisis, with sanctions, the funding this year will be even decreased in comparison to the previous year. And so this is also not supported by concrete actions. And NGOs are in the role, maybe, I think many of you know that there was this repressive law against NGOs who can be considered as foreign agents, spies. Well, humanitarian action passed through a severe control of the structures which are supposed to control NGOs. We are not acknowledged like spies, but it took a year of time that could be spent in another way, just a more constructive way. As you can imagine, this doesn't contribute to normal functioning of harm reduction programs and to normal dialogue. Society. As I told, there is no democratic tradition. As a consequence, no tradition of public discussion. What we are observing more and more in a very important scale is the return to the traditionalist values. You know, Russian spirituality and morality. We will struggle against HIV and against drug use epidemic, only with our Saint Russia spirituality and family values. I don't comment this. And a very important point is also the weakness of the civil society. I will not mention the reasons. There are multiple reasons of this weakness, but it's the fact. Only some NGOs dare to speak about the problems in an open way. So what is humanitarian action? The NGO that I represent, an NGO in St. Petersburg. It is purely a community-based association. More than the half of staff are people who belong to one or some key groups. And till today, this is the sole NGO which provides harm reduction services in St. Petersburg. As you can imagine, for the city of 5 million of inhabitants and the number of drug users estimated, it's not enough, of course. So the program is since 1997. It still runs, and we are still the sole NGO. There is one harm reduction service at the infectious diseases hospital, but it's not really connected with the field because they don't do outreach, even if their role is very important. So target groups, people who inject drugs. Why who inject? Because, as I told, some new drugs are coming more and more on the scene, but we have not really contact with new drugs users. And we don't know what to do. It's our problem. Maybe I'll find an answer during this conference. Then sex workers using drugs. First of all, street female sex workers. And in St. Petersburg, the girls, the women who work in the streets are almost 100% drug users, injected drug users. People living with HIV in general, and a special target group, official health structures, police, courts, NGOs, every structure related to the problem. Now, I'm sorry for this scheme, which is in reality is not very complicated. Simply it's written in French, but I suppose it's not a problem. I will try to explain. In gray, you see the community of IDUs, street IDUs, and sex workers IDUs. Then we are in contact with this community due to food outreach work. Then we have a big bus specially arranged for needle exchange, counseling, blood testing, and information. We have a van for sexual workers. And we have a special bus for the general population testing, which was a little bit imposed by donors. It's not really our strong side, but we accepted this because they contribute to funding of harm reduction. The blue circle, as you see, I especially accentuated this aspect, the patronage of heavy cases or difficult cases. We observe more and more difficult cases. Very acute health problems, especially TB, co-infection TB, HIV is really something, a very important problem. So the green figure is the unit of accompaniment of our clients. So you see the first step just on the stage of low threshold activities, and then we are trying to motivate people to go further, to solve their problems. And we have a special staff of case management because we are working case by case. It's always very individual. And the last structure, blue structure, is the network of friendly structures and specialists with whom we have established a good partnership. With hospitals, rehabilitation centers, because they are demanded. social protection services, psychologists, and finally police, with whom we have a special project of drug users referral to medical structures due to our case management unit. It's only on the scale of one city district. It doesn't go really well. We were expecting that it will go better, but in any way, just that they agree, the fact that they agreed to have cooperation with us, and I speak about not really criminal cases, but cases which are not connected with crime, for heavy criminal cases, when we know that the protection is needed, we have a lawyer who defend our clients, and even more, we have independent public defenders who are the guys from my association who go to the court to discuss, to assist a little bit our clients, because they are not really active in self-protection. And we have a training unit, which is a kind of tool to establish partnership, because we are doing trainings not only for our units, but for partner organizations too. Well, a little bit just harm reduction bus, the process of work, the van for sex workers, food outreach, and maybe not the best picture of accompaniment, people who are hospitalized at the Butkin Hospital for infectious diseases, where conditions are really poor, but in any way, this was the first structure which opened the door to us and to, especially to our clients. Some just main results. You see number of clients, about 5,000, among them 684 who were accompanied into official structures. These are accomplished cases when, because we normally elaborate the project, we sign the agreement with the client, and case managers work just to help people to do what they have planned. Number of distributed syringes is 178,000, and condoms about 300,000. Main, I should say, metaphysical results. We happen to have city funding, what is really a very rare case for Russia, where the official structures are not participating in fundings. What is just $70,000, what is 10% of our annual budget. It's not really much, but indeed, humanitarian action, due to its fidelity to the people with whom we work and to the professionalism, became a reference NGO in the region. We are doing trainings for many other structures, both governmental and non-governmental, in the region of Eastern Europe. And it became a center of a sustainable partnership network in the city. What is maybe the main result of our activities. Now, why I'm speaking about this? Because humanitarian action became a driver of elaboration of the consensus, the famous consensus that we have been speaking yesterday about, on the local level. You see the situation on the federal level, which is catastrophic. However, on the city level, we happen to achieve some changes. Humanitarian Action is an NGO. I'm sorry, just a little bit of reflection. An NGO is not in the position to write law. I think you agree. But an NGO is the best positioned to bear witness, which is, in fact, the base for elaborating consensus and for changing. Just to finish, regarding yesterday's discussion, what is harm reduction? Because I'm pure from the harm reduction. So for me, it's providing of needed services. Accentuate the needed services, because it's not something like, you know, we can take and impose. We have to know very well the needs. Somewhere this is the bus, somewhere this is like in Bogota, distribution of marijuana instead of cocaine. It must be adapted to the needs. And I permit myself to be a little bit pathetic. I was also like this, but I think it's true. For me, harm reduction is the rehabilitation of the human dignity of people with whom we work. Thank you very much.
Możemy sobie pozwolić na 1-2 pytania od publiczności czasowo, jeżeli ktoś z Państwa... O.
Dziękuję. Ja mam pytanie do Daszy. Dziękuję w ogóle wszystkim prelegentom za bardzo interesujące prezentacje dotyczące sytuacji na wschodzie. Oglądając Daszy prezentację, to można było się nawet dobrze poczuć, jak porównaliśmy sytuację w Polsce do sytuacji na przykład w krajach bałtyckich, gdzie u nas używanie narkotyków nie jest karane, co ma miejsce na przykład w Litwie czy na Łotwie. I moje takie pytanie, bo wiem, że ten raport jest dosyć duży, ta cała analiza, było wiele osób zaangażowanych, niektóre z nich znam z krajów bałtyckich. Jakie są pomysły, rekomendacje na zmianę tej sytuacji, tak? Na wpłynięcie na te kraje, tak? Żeby tą sytuację troszeczkę zmienić. Ja wiem, że to nie jest łatwe, ponieważ nawet my z polskiego podwórka wprowadziliśmy rozwiązania w kierunku depenalizacji w 2011 roku i to był krok w dobrą stronę, jednakże sama zmiana prawa nie wystarczy. Mamy tutaj wyzwania związane z implementacją tych rozwiązań idących w kierunku depenalizacji. I tu kwestia jest troszkę taka, że na poziomie merytorycznym, naukowym mamy dyskusję, widzimy pewne rozwiązania, no ale ten klucz jest u polityków, tak? To jest w rękach politycznych. O ile dobrze zrozumiałem, to jest tu pomysł związany z UNGAS, tak, żeby za pomocą tej drogi próbować zmienić sytuację. No ale pytanie, na ile to będzie miało przełożenie na poszczególne różne kraje. Dziękuję.
Thank you. Can you hear me? Thank you for the question. Well, to put it briefly, our vision is that the action should be the action to strengthen or to give any chances to drug policy reform should happen from both sides. So on the one hand, we believe that the civil society and scientific community should be collecting the negative consequences of prohibition in terms of how much does it cost to the society, both in financial, way, and also in costs in terms of health impact, human rights impact, and all the framework that I've just presented. But I believe that would not be enough to change the situation in Latvia and Lithuania, for instance, and in many other countries to the east. So for those countries which are part of the European Union, what we hear from the politicians is that they need a strong stronger recommendations from the European Union level. So this is what we hear from people who are in charge of drug policy related decisions, at least in Latvia and Estonia. So if there would be a kind of pressure, if I may say so, a pressure from the European Union level to decriminalize drugs, if there would be a European court decision that criminalization of drug use or drug possession of more than, of some micro amount of heroin is illegal, that it violates human rights, then there would be some change. So we should be pushing from two sides, from the ground level cooperation between health professionals, scientists, and the civil society and the European Commission level. I do not have a feeling that the gas process itself would lead to any changes in the Baltic states, neither in many other countries. But in countries like Ukraine, for instance, the country which is today quite open to hear what the world thinks about the situation in Ukraine, we see that we can use all these discussions at the Commission on Narcotic Drugs, at gas, at the European Union level, and that Ukraine, for instance, and perhaps Moldova in a way, are quite perceptive to what they hear. And just one example, a very recent example from Georgia, they had a long history of street drug testing, so people could get, there was random testing for drugs in streets, and people had to pay very high fines if they were positive, if they have used drugs. So there was a recommendation from the European Union that Georgia should change this policy, and they changed it. We are still not happy. The civil society is never happy with how the things work. But anyway, we see that this influence can be created. But here we need partners from Poland, we need partners from Czech Republic, from Hungary, etc. Because we believe that you as our neighbors could have more influence on this than countries to, the Western Europe. Thank you.